Good afternoon, everyone, and thank you for joining us. This is Paige Hancock, Marketing Manager at Spok, and I'll be your moderator for today's webinar. Today, we'll be talking about completing the puzzle for an integrated communications strategy. Gerard Shallow, Director of Product Marketing at Spok, will share how a unified technology platform can solve multiple challenges, and we'll also take a look at some specific hospital workflow examples. Before we get started, I would like to go over some housekeeping items. Everyone will be muted during today's webinar, but we still want your participation. Please submit your questions via the questions box that's in your GoToWebinar toolbar, and then Gerard will answer as many questions as time allows after the presentation. A recording of this webinar and the presentation slides will be sent to all registrants tomorrow, and please feel free to share these with others at your organization. You'll have the opportunity to complete an evaluation at the end of the webinar as well. We would love it if you could take a couple of minutes to complete this survey, as we truly take your feedback into account, and your thoughts help our efforts to provide relevant and informative presentations. And with that, I'd like to turn it over to Gerard, who will begin our presentation.
All right, thank you, Paige. So before we get into it, I just wanted to take a second and remind everyone that this week is National Health IT Week, and that takes place every year and focuses on improving healthcare through advances in technology. And a big initiative this year has been for people to share some of their stories online and recognize why it is that they care about healthcare IT by taking a photo such as the one here of me and sharing it on social media with the hashtag #IHeartHIT. A couple weeks ago at Spok's Regional Connect Conference in Chicago, we had a number of Spok employees as well as a number of our customers that were in attendance who took photos similar to the one seen here with me, and we've shared those in a video and put them out through our social media channels. And we'd really love to hear your thoughts on why it is that you love and are committed to being involved in healthcare IT and the healthcare IT field by sharing this on social media using the same Health IT hashtag. Okay, so let's start today's webinar with just a little background on Spok, just for anyone on the call today who might be less than familiar with us. So, at our core, this is our purpose and this is who we are. So Spok is passionate about critical communications in healthcare, and for Spok, every message is important because we know that the minutes and the seconds matter in a hospital when a patient's lives are at stake. So this is how we work with our customers. We work with them to evolve the communications systems that they have in their hospital from often disjointed, non-interoperating systems to a single communications platform that allows for sharing of important data such as directory schedules and preferences across different applications. So some of the challenges that our customers see in healthcare are how to effectively deliver critical test results to those who are on the care team, interoperability challenges with all the many systems and applications that are implemented in a typical hospital, providers that complain of alarm fatigue. We have to ensure that the organization is in compliance with HIPAA and other regulatory requirements. There's increasing expectations around mobility and BYOD policies and MDM. There's the need to figure out who's on call and how to automate the notification process, improve patient satisfaction and raise HCAHPS scores, and of course there's dealing with multiple and disparate data sources. And it's our view, it's Spok's view, that hospitals don't have to look at these as individual and unrelated challenges. We know that it's possible for one unified technology platform to help solve multiple challenges across different areas and different departments of the hospital. So what tends to happen is many hospitals find themselves piecing together a clinical communication solution from a number of different vendors. The problem is that these vendors all have totally separate data sources and often don't talk with one another. And that means that valuable data from one system can't be shared with or influence a workflow that's managed by another system. And that impacts productivity of clinicians and, of course, in turn impacts patient care. So this approach this siloed approach that is taken by a lot of hospitals is not the ideal. So here's how Spok is different, and here's a big part of the basis for today's webinar. The hospitals that implement the Spok Care Connect platform consider it the heart of enterprise communications for their facility, and they consider it the single source for 3 very important types of information that you'll hear come up again and again throughout the course of today's webinar, and that is directory information, scheduling data, and messaging preferences. So these data points, directory, schedule, and preferences, will be able to dictate the path that communications flow, whether that's just a simple consult request that's generated by one clinician and sent to another clinician, or if it's a critical biometric alert that needs to immediately notify a patient's entire care team. So the Spok Care Connect platform is a platform that will help you improve workflows across the hospital. So from the contact center to the patient's bedside, from doctors and nurses to housekeeping and transport staff. So because Spok Care Connect as a suite is an integrated set of solutions, it delivers information often securely and quickly into the hands of the clinicians who need to act on it. That is, wherever they might be and whatever device it is that they might be using. So as a sort of a form of comparison here, you might think about Microsoft Office. So at one time, it was very common for organizations to install and then support separate applications for word processing, for spreadsheet management, and then another still for graphics. But there was no easy exchange of data between these different programs. So data, imagery, formatting from one then can't easily be used in another. And today we can't imagine this because we have Microsoft Office. So Office is a fully integrated suite that covers a whole range of needs across an organization, from marketing to accounting. And this is the same concept as Spok. We have that one solution, one platform approach. We think that the days of disparate technologies won't last in healthcare because of the data interface issues, just like before EMRs, which compromise patient safety and of course, compromise patient outcomes. So here's just a little bit about the Spok vision and some of the trends that our customers are talking about. One is enterprise collaboration. So hospitals don't want separate systems for doctors to communicate amongst themselves and don't want a separate system for nurses to do the same. There needs to be a single collaborative platform that enables communications across an entire care team. We're also seeing a lot of new rules and regulations in healthcare, and there's a growing set of standards that hospitals are being held accountable for, from HIPAA and high-tech to the Joint Commission, and then the reimbursement impact from the Affordable Care Act. And Spok is able to help you meet many of these new sets of standards. Across the hospitals, there's new systems to integrate. So your hospital today has a number of systems around patient care that contain disparate data with no form of interoperability. And our vision is for systems such as your EMR, for patient monitors, even your telephony network, all to be part of the same heart of communications. Systems interoperability is also a big concern for hospitals. And our vision is communications with context. And what that means is that data that exists in the EMR or exists within a patient monitoring system should not only be delivered to a particular endpoint, but in some cases should drive which endpoint it is that's delivered to. An example might be let's say a low battery alert for a telemetry monitor. That shouldn't bother clinical staff. It should bypass clinical staff and instead be sent to a tech who's in a position to respond. Versus a critical heart monitor alert. So that's something that needs to be sent as a high priority to a patient's entire care team. So it's the same alerting system, but different endpoints, different folks, different care team members to notify, and different priorities. Also, fast data is something that we're hearing about. A lot of people out there are talking about big data, but at Spok, we solve fast data. We cut through the volumes of alarms and alerts, filtering and prioritization to get the right alarms to the right caregivers. So those are some of the trends that we talk about and we hear about within the industry from our customers. So in a moment, we're going to see some of the use case examples of Spok in action. And what you're going to see is that Spok technology is all about helping clinicians deliver well-coordinated care. And that's with the intention of improving the patient's experience and ensuring quality outcomes. Our technology helps you comply with industry regulations from HIPAA, high-tech, the Joint Commission, and others. And overall, we're all about helping hospitals simplify critical enterprise communications by delivering the right information to the right person on the right device at the right time. So what we're going to get into now is a look at Spok technology in action. And I'm going to spend a little bit of time talking about different workflows, different use cases for our technology, so you can kind of get a better understanding of the value of a fully integrated communications platform in the context of everyday workflow for clinicians. And the reason that we talk about workflows, there's a couple big reasons. One is that it's not a single product approach. It covers a number of different solutions across the organization. So it's technology that is not used by a single department in a single area of the hospital. It's something that's shared throughout the organization. And if you think about the term solution, vendors use it so much that sometimes we might forget its meaning. You know, our goal as a solutions provider is to understand your challenges in healthcare and the challenges that you're facing on a daily basis, and then attach a solution to those challenges. And that's the way we view our technology, as a solution to the challenges that you're seeing every day within healthcare communications. So the first area we're going to get into today is that of a nurse call. So here's a scenario that might feel very familiar to you, might be taking place across your hospital, and that is patient in a bed hits their nurse call button. So what happens is that it might light a light outside the patient's room door, or send a notification that's received at a central nursing station. So someone that's stationed at that nursing station sees that, has to refer to a staff assignment system or some method of assigning a nurse with that room or that bed, go and track down that nurse who's inevitably going to be busy doing something else. And when he or she has time, they're going to walk down the hall, visit with the patient, determine their need, and then figure out the follow-up. So nurses, as you might expect and as you probably know, walk a great deal throughout the course of their day. During a 12-hour night shift, they might walk up to 3 miles, largely related to the workflow that we just looked at a moment ago. And during the day, during an average 12-hour shift, when everyone's awake and everyone has needs, they might walk up to 5 miles. So while walking is good and healthy for all of us, the challenge here for a clinician is that when they're walking, they're not directly caring for a patient. It's essentially wasted time that they're not by the patient's bedside directly caring for a patient. So here's how we can improve some of that process. When that same patient hits their nurse call button, we can bypass that nursing station and instead send that nurse call notification out to whatever mobile device is being carried by that nurse. It could be an in-house wireless phone from a SpectraLink, or vendors such as SpectraLink. It could be a pager. It could be, as seen here, a smartphone. So when just to use an example of the smartphone, when that nurse receives the message, they're able to use the telephone capability of a SpectraLink device, of a smartphone, call back and speak with the patient via their nurse call system's pillow speaker, determine what the need is. Do they simply want a glass of water? Are they in pain? Do they need an assist to the restroom because they're a fall risk? What is the need for that patient? Let's say it's a medication request. Right from that same interface, Spok can enable the nurse, as the recipient of that message, to send a secure encrypted message to the attending physician for that patient, letting them know that there's a request for pain medication. That doctor can then take that and put in an order through a CPOE system. The nurse is able to take care of the situation, remedy the situation. The patient gets what it is they need, whether it's medication or that assist to the restroom quickly. So it's good for the patient, good for the nurse. We're greatly improving the process around a nurse call. Let's look at another scenario around the patient admit. So typically what happens is that admission staff, when a new patient is admitted, updates the ADT system, and perhaps the ED physician and the attending physician need to discuss the patient's case. So somebody, perhaps the nurse, asks the operator to intervene here and send a page to the attending physician. Inevitably, that physician is going to be unavailable, and the patient sits and waits until the ED physician and the attending physician are finally able to discuss the patient's case. And of course, there's a few different breakdowns in communication here. Much like we just looked at with the nurse call example, we can automate this process. So when there is that ADT event, when the admission staff updates the ADT system, we can send that admit notification directly to whatever mobile device is being carried by the attending physician, and it could look something similar to what you see here. We can send a secure encrypted message, perhaps to a smartphone, that because it's secure and encrypted can contain the patient's information, additional information about the patient, what location they are, the room that they've been assigned to, who the admitting physician is, allowing the attending physician as the recipient of this message to click on the number here and use the phone capability, again, whether that's a smartphone, whether that's a SpectraLink type of device, to speak with the ED physician, have that consultation, and quickly get the information they need to visit with the patient. Much the same way, during the course of an admit, we can do the same thing for a nurse. We can send that same patient admit note to the nurse with the same basic information. Nurse doesn't have to speak with the admitting physician. All he or she needs to do is acknowledge that they've received the message, which we log within our system, and then the nurse can visit the patient and complete their assessment. So just some improvements that can be made with technology to the admission process. Same thing on the back end. When a patient's ready to be discharged, typically what happens is we see an attending physician for that patient write a note stating that this discharge is okayed pending approval from some specialist. So whatever specialist is attending to that or assigned to that patient. So the nurse or someone has to track down the specialist to gain the approval. And what happens with the patient? They sit by anxiously awaiting the final okay to be discharged. But in the meantime, these two individuals, these two physicians, have to speak with one another. What we can do is, when that patient's ready to be discharged, allow for a quick, easy lookup by the attending and send a secure message to the specialist to get discharge approval. That approval can happen quickly, can be sent from the attending physician, can be sent by the nurse. We can get that okay to discharge quickly and get the patient out and on their way. Good for the patient and good for the hospital, because we're improving discharge times and improving patient turnover. Let's look at another scenario, that around orders or instruction notification. So if we have a scenario where Dr. Gold is the attending physician for a patient named Jill, Dr. Gold visits with Jill and determines as part of her discharge she needs to take her medication twice a day. So Dr. Gold is going to take this as his doctor's orders and put it into Jill's medical record, put it into the EMR system. What Spok is able to do here is take that doctor's note, that doctor's orders for meds twice daily, and send this as a discharge note to the nurse that's assigned to Jill. We can reference on-call schedules. We can reference staff assignment system to determine who the right endpoint is for these discharge notes. And again, we can help speed up the discharge process there. Good for patient, good for the hospital. Okay, so where we're going to continue now is to talk about some communication goals that revolve around the Joint Commission's national patient safety goals. And many of you might be familiar with the Joint Commission's national patient safety goals, which they publish and update yearly. One particular national patient safety goal, number 3, talks about the improving the safety of clinical alarm systems, and that's going to be the nature of some of what we look at in a moment. And specifically, National Patient Safety Goal 060101 specifically speaks to diminishing alarm fatigue. And I'm sure that's a phrase that many of you have heard and many of you are familiar with, and you've probably heard discussed throughout your hospital about the clinicians and the many alerts and alarms that they hear during the course of their day. And that is quite numerous. There's a study that's been done that speaks to alarm conditions and states that there are 350 in the average U.S. hospital of these alarm conditions per bed every day in the average U.S. hospital. So if you imagine a nurse who during the course of their shift is responsible for 4, 5, 6 beds, to do the math there, that's a lot of alerts and alarms and a lot of noise that contributes to alarm fatigue. And really amazing is that anywhere from 85 to 99% of these 350 alarm conditions per bed per day are non-actionable. That means the vast majority of these don't require the nurse or the clinician or whoever is hearing these or notified to do anything. They're just interruptions. It's just alarm fatigue. It's just noise. And a lot of the story around our technology is how to better navigate this. A lot of the basis for Spok and our solutions is around communicating with the right people throughout the clinical side of your hospital. It's about getting lab results and delivering them to the attending physician or the ordering physician for a particular patient, taking the notifications from patient care devices and putting those to the clinicians who are best in a position to respond to those. Even facility systems, ordering systems, non-clinical systems such as fire alarms, door access controls, all the many systems that generate alarms and alerts throughout the hospital can, instead of just making audible sounds, be directed to the mobile devices being carried by the person in the position to follow up. So let's look at a couple examples there, and we kind of alluded to this scenario earlier. A lot of this is based around priority of an alert. So let's say we have a telemetry alarm, and the alarm sounds, and all it is that there's a battery within that telemetry alarm is low. So nurse hears this, visits the telemetry alarm by the patient's bedside, sees that it's just a battery low, says, okay, I need to bring someone else in here. I need to bring in a tech who's able to respond to this. Goes, notifies that tech. We wait for the tech to follow up. The nurse has been taken out of whatever they were doing to go and attend to this, whereas it's not something that really needs their attention at all. What our technology, what Spok is able to do, is take that same notification from that same telemetry alarm and recognize that the type of alarm it is, recognize that it's not just a generic alarm, it's a low battery and perhaps therefore a low priority message. And we can bypass the clinicians altogether, bypass the nurses altogether with this notification. We know, our technology knows, that a message, an alert of this type needs to be directed to a tech. And we can send it to whatever device it is that they're carrying. The example that we see here on the screen is a SpectraLink pivot device. So we can send that as a low priority message to the person who's, again, best in position to respond to that, have them evaluate and fix whatever it is needs to be followed up on. And meanwhile, again, the nurse, the clinicians are never interrupted with this type of message that doesn't require their attention. So if you contrast that to a situation with perhaps a very similar, perhaps the same system, if it's a V-FIB, a ventricular fibrillation alarm. So now we're talking about a critical heart monitor that sounds. This is something that's very important. This is something that doesn't need to go to just one individual or one clinician. This is something that needs to be sent to an entire care team for this particular patient. So now we can take that message, recognize the type of message it is, assign a high priority to this, send it out to a number of individuals that make up that patient's care team, and send that as a high priority message, again, to whatever device they might be carrying. And if they're carrying something similar to what you see here, the SpectraLink pivot, or if they're carrying a Spok mobile device on or a smartphone running the Spok mobile application, we can notify them not only with a visual that it's a high priority message, but also tailor a ring counter or some sort of device-based alarm that indicates audibly that this is a high priority message, and allow for the care team to immediately get that message. We can bring in escalations if necessary to other members of the care team or others who might need to be notified if a member of the care team doesn't respond, and make sure that that patient is cared for immediately. Another note I want to make is around some of these messages that we've talked about and our ability to add clinical context. So we've talked about messages that were sent to mobile devices from nurse call systems. We've talked about messages that were sent to mobile devices from around codes and around telemetry systems and patient monitors. Along with those messages, we have the ability to take from the ADT system a bit of additional information, add that to the message, and send it out to a mobile device. So let's say we have a patient that is requesting, that hits their nurse call button because they want an assist to the restroom, and they're a fall risk. So they are noted within the system as being a fall risk. We can send that nurse call along with that information, that patient is in fact a fall risk, to the mobile device for the nurse, just giving them a little bit of context and say, they might need that assist and they're a fall risk. You might want to respond to this quickly so as to avoid them getting up and trying to walk to the restroom on their own. Same thing as you see here in the example we have on the screen. We can send allergy information perhaps, or medication information along with the appropriate message. Continuing down the path of National Patient Safety Goal. National Patient Safety Goal number 2 speaks to improving the safety and effectiveness of communications among caregivers, and specifically 020301 talks about critical test results and talks about reporting of critical test results and diagnostic procedures on a timely basis. So there's a National Patient Safety Goal that specifically talks about results and test results. And there's a number of reasons why. For starters, when test results are specifically cited as a factor in a malpractice case, the most common problem is that the patient didn't receive the test results, and the second most common problem is that the clinician didn't receive the test results. So within malpractice cases, 3/4 of these malpractice cases are communications related. So there's an obvious need to improve communications around test results and critical test results, and that's why the National Patient Safety Goal specifically cites that as a goal for hospitals by the Joint Commission. There's many tests performed in the U.S. every year. There's in fact 400 million radiology exams that are performed in the U.S. every year, and there's 6.8 billion lab tests that are performed in the U.S. every year. So these many millions and billions of tests that are performed obviously mean millions and billions of results, and a portion of those are critical and therefore require immediate follow-up. So let's look at another workflow that, again, might be familiar to any of you who have contact with either labs or radiology departments. So if we have an attending physician for a patient, they recommend that that patient have an x-ray done. The radiologist reads that and the results come back critical. So there's something here that needs follow-up for that patient. What has to happen is the radiologist or someone within the radiology group picks up a phone, has to call the ordering physician for that test, speak to them about what the findings are. Inevitably, there's going to be a game of phone tag as the radiologist calls the clinician or the physician does not take that call, is busy, tries to call back, the radiologist has moved on to another reading. So there's a period of time between when the critical finding has been made and when the patient is waiting for treatment. They're there knowing that they've had an x-ray done, or perhaps have had labs drawn, and they're waiting to hear what the results are. So we can improve this much the similar way as we've looked at with a few other workflows. During that same process, when the radiologist recommends that a radiologist performs the x-ray and the results come back critical, what we're able to do is take the radiologist's dictation into the radiology information system, take a feed from that, and send those findings directly to, again, whatever device is being carried by the ordering physician, the attending physician, or whoever you determine is the person that needs to be notified for these results. So if that ordering physician is carrying a device that enables secure, encrypted communications, we can send the full findings detail, including patient's name, the dictated findings from the radiologist, all this sensitive patient information we're able to send because it's secure and encrypted. We can even pass along the sender's phone, that being the radiologist, to allow if the recipient determines they want to speak further with them, just a one-touch and allow for them to speak with one another. If this is an x-ray that's been done or a scan that's been done, and there is an image that pairs with it, and that's within the hospital's PACS system, we can also pass along a link to the PACS viewer so that the recipient can click on that, log in, and we've passed along the ID for that specific image in question and allow them to view it right from their mobile device. We also kind of close the loop on this communication because the recipient, perhaps the ordering physician for this test, sees the message as you see on the screen here, and that message comes with an accept or decline button. Well, by accepting it, we're taking that as fact that the ordering physician or the recipient has seen the message, seen the findings from the radiologist or the lab tech or whomever, and we're writing that back to the patient's record. So now the patient's record has from Spok a notation that not only here are the findings from the radiology information system, but also that the ordering physician, Dr. Johnson, has seen this on Friday afternoon at 3 p.m. and has acknowledged that they've seen it. So by streamlining that process, we're able to allow for the clinicians to begin treatment far sooner than with that game of phone tag getting in the way. So let's talk for a minute about escalations. And these escalations sort of run across the board and cover all of the different workflows that we've been talking about. So let's just use the workflow that we just looked at as sort of the context for what we're able to bring to your organization in terms of message escalation. So that same scenario where we have a radiologist that has seen a critical finding and logged that into the system. If that information needs to be passed on to the ordering physician, they might get that on their mobile device as a text-based message. But what happens if a period of time, let's say 2 minutes go by, and the recipient of that message, the ordering physician, has not interacted with the message, has not acknowledged that they've seen that message? Well, that particular physician might have had a secondary device specified. They might say, well, if you don't get me first on this device for these types of messages, what I want is a call put out to my mobile device. So what Spok is able to do is we have a text-to-speech element that takes the text of the message, puts out a call to the phone as determined by the intended recipient, and puts out a call to them and reads out the findings as would come across in text form on a mobile device. But let's say that intended recipient still, after 5 minutes, hasn't answered the call. We're able to bring in yet another type of escalation, and that is to escalate to another individual entirely. So now we've looked at two different types of escalations that we can introduce into the mix here. One is device-based. So if you don't get me on this device or this device, try me on this device. So you're trying numerous different devices for an individual. The secondary type of escalation is an individual escalation. So now we've determined after trying 2 or 3 different devices for a particular intended recipient, we can escalate to another individual altogether and then follow their preferred device hierarchy. So I just wanted to use what we just talked about, the critical test results communication, as context for the different types of escalations of messages that we can bring in here. And that applies, of course, not just to critical test results being communicated, but much of what we've looked at so far, biometric alerts, patient alarms, nurse calls. All of these can follow escalations as we just looked at. Next area we're going to look at is that around a code STEMI. So I'm sure many of you are familiar with code STEMI. Code STEMI is ST segment elevation myocardial infarction, which is a fancy way of saying heart attack. So code STEMI and door to balloon time is something that was determined back in 2006 by the Joint Commission to be measured by every hospital, and it was advised that there be a 90-minute door to balloon time from when a heart attack victim entered the hospital until they were receiving treatment from the cath lab. That's where the balloon comes from in the door to balloon time phrase. So this 90-minute window was then echoed by the American Hospital Association and the American College of Cardiology, and it's a metric that every hospital, including yours, tracks. So we've worked with a few customers on improving their code STEMI procedure and they're improving their door to balloon time. So what tends to happen is this is a very manual process. We have a response team for code STEMI that's made up of a number of different specialists and a number of different roles, from someone from the cath lab staff to the lab techs, an ER shift coordinator, all of these different individuals who need to be aware of the situation and who need to be ready to respond. And again, this is a manual process where someone or a couple people are responsible during the code STEMI for picking up a phone, dialing a number of different individuals. If they don't get those people to answer their phone or they don't respond to a page that's been sent to them, they have to reference on-call schedules and directories and figure out who the next person is for that role, and you can see why it takes a good amount of time to complete that process and fill that code STEMI response team. What we've done for a customer, one particular customer who is reporting a 129-minute door-to-balloon time, is to automate this process. So we build all of these code STEMI procedures beforehand so that when the code STEMI actually takes place, we're essentially just pulling the trigger and sending out automated notifications to whatever device is being carried by the members of the cath lab and all the different roles that need to be filled. And if they respond that they're available within a certain period of time, we no longer put out that notification. If they don't respond within a specified period of time, much like the escalation example that we looked at a moment ago, we're escalating to other devices being carried by that individual or someone else entirely. So we're completely automating this process. And for this particular customer, we had cut down their 129-minute door-to-balloon time with the manual process nearly in half to 68 minutes. So by having all of that data in place, from directory to on-call, and being able to put out voice calls as well as text-based messages to mobile devices and pagers and smartphones, we're greatly improving the process, and of course greatly improving patient care around the code STEMI. Another area we're going to look at, another code type, is a code blue, and we're going to look at this because it involves a few different areas of the hospital. So when we have a nurse that hits the code button in the patient's room, of course we're going to take that and deliver that as a high priority message, much as the example we looked at earlier, to the care team for that patient on the devices that they might be carrying. We also might notify the operators. So we can send through our operator console, we can integrate them into the clinical side and the code process, because a lot of times operators have further tasks around a code that they need to do. Maybe there's an overhead page that needs to go out. So not only when we have these critical codes that are called, often the call center group, those in the contact center, are involved just as much as some of the care team are. So the care teams are the ones that need to be notified on mobile devices and immediately respond. The operators have their own tasks, so we're able to weave them in to the code process as well. Another thing that we're able to do, and another way that we interoperate with an EMR, is for patient reminders. So when a patient, in this case Jeff, is discharged with instructions for taking his medication, Jeff's physician might determine that he's an at-risk patient and doesn't want to see him readmitted to the hospital, because under the Affordable Care Act, readmissions are not reimbursed. So reimbursement for a hospital stay needs to be protected by avoiding readmissions. So what we want to do for medication instructions or any sort of follow-up instructions for a patient is to send that through SMS, take those notes directly from the EMR, from the medical record for that patient, and then put out a SMS message to that patient's cell phone. So we can send them the instructions as entered into the EMR by their doctor, just to give them those instructions after they've been discharged, just to make sure that they're following their doctor's instructions and try to avoid as best we can them being readmitted, and therefore protect reimbursement for the hospital. So I know that was quite a lot to cover over the course of this webinar, but it looks like we do have a few more minutes for questions. So I guess, Paige, I will kick it back to you to take some of the questions that might have come in as I've been speaking.
Awesome. Thank you, Gerard, and thank you for that insightful presentation. We will take the time now to answer your questions, and it looks like a few of you have submitted already. If you have a question, please do submit it in the questions box, and then we'll answer as many as time allows. So, Gerard, our first question is, what happens if the nurse or doctor gets an alert but they can't respond? Gerard, you might be on mute. We can't hear you.
Oh, my apologies.
Okay.
So anyone across the hospital, whether it's a doctor, nurse, member of housekeeping staff, anyone who's getting any sort of message, be it a message from another individual that's been entered into, let's say, the mobile app, or a message from a third-party system, nurse call, telemetry system, if they don't respond to that message, we can bring in all these different types of escalations, whether that's escalating to another device that's being carried by that particular intended recipient, or if a certain period of time and the period that period of escalation is determined by the users of the system. It's not something that's built into the system. So you determine those periods of escalation. We can escalate to another recipient altogether by referencing an on-call schedule. So if the message is intended to be sent to me, if I don't respond to that message, we can either name another recipient. Let's say it needs to be escalated to Dr. Johnson if I don't respond, or we can name another role. So if I don't respond and I'm a cardiologist, we can escalate to the current on-call cardiologist.
Excellent, thank you. Another attendee has asked, how are all of these solutions integrated?
So we are a single, that's the big differentiator for Spok, is that we have a single platform for all of these different back-end technologies. So we're able to take the many different systems throughout the hospital, third-party systems, nurse call system, all the many patient alert monitoring systems, even the telephony network of the hospital, and tie them all together. So it's all through our platform's integrations that we have with these many systems, and the back-end data that serves as sort of the heart of communications that we manage, which are directory, schedules, and preferences data, preference data being related to all the escalation capabilities that we talked about a moment ago. So it's all of that back-end data that we're able to use to determine the flow of a message. So whether that message is, again, from a third-party system or from an individual, we'll take all of the different data points that we have, name data, meaning directory data, the schedule, who's on call for a particular role, the preferences, based on if it's a high priority message, a low priority message, do you want it on this device versus that device? Should it escalate to this person versus that person? So it's that single platform that we offer that takes in all these many integrations and is able to communicate with all many different types of mobile devices that are being carried by clinicians. That is really the foundation for what we do.
Thank you. And our next question is your secure texting solution HIPAA compliant?
It is. What makes a secure texting solution HIPAA compliant is the vendor's willingness and ability to provide a business associate agreement, which is a BAA, and that is something that we do provide, and that just states that we are able to handle and be compliant with HIPAA regulations in the handling of sensitive electronic protected health information. So we are HIPAA compliant in that we not only encrypt data, and the way we encrypt data and secure data is a whole other conversation that we're happy to have with you, but we will also provide a BAA and state that we are in compliance with HIPAA.
Thank you. And a follow-up question to that one, is it cloud-based or is it behind the facility firewall server?
This is behind the organization's firewall. So this is something that is on-premise. This is a system that is on-premise. So the data and the sensitive patient information never leaves your network.
Thank you. So another question here. Looks like we're running out of time, but we have a couple more that we'll get through. Do you have any suggestions on how to successfully roll out new technology like this?
That is a conversation into itself. I would say that we do have quite a lot of experience in this and quite a number of suggestions, and we in fact have an entire department here at Spok that's dedicated to working with our customers to roll out any of our solutions, most notably secure texting, which often is a whole new dynamic for our users and doctors and nurses. So we do a series of webinars that talk about introducing secure texting and other technologies within your facility. I'd suggest keeping an eye out and attending some of those. Really, it all comes down to buy-in and across the facility for these types of technologies. You know, secure texting is a good example. It's not just an IT team going out researching a vendor and bringing them in and forcing it into the hands of doctors and nurses and anyone who might be using that product. It's making sure from the beginning that these stakeholders, these clinicians, have a say in the selection of the right tool. So yeah, that's a very big conversation to have, but one that we're very well equipped to have with you.
Thank you. It looks like we have time for just one last question. So one more, Gerard. Are the responders, the physicians and nurses, carrying their own personal device, or are they carrying hospital-provided devices?
Both. We work with customers that have both models, sometimes both in the same facility. So BYOD is a term you probably often hear, bring your own device. In that model, we have let's say a nurse who brings their own smartphone, but the hospital will work with them to install a mobile application such as ours and support that mobile app. And we can work with you on a BYOD model. If we're talking about hospital-issued devices, that's certainly something we can do easily. In both cases, we work closely with mobile device management or MDM solutions to help manage settings within the systems, help manage upgrades to the app, and so forth. So we work very well in both models, often within the same facility.
Thank you. Unfortunately, we are out of time, so we'll conclude the webinar there for today. If we were unable to get to your question today, we will be sure to follow up with you. And if you'd like to chat with a Spok representative on the topics that we discussed today, you can do so using the link that's in the chat box. You can also continue the conversation with fellow attendees by using the hashtag SpokWebinar on Twitter. And follow us on Twitter, LinkedIn, and Facebook to get all of the latest news from Spok, as well as industry news and trends. Thank you all again for joining us. We hope that you found this webinar informative and that you have a great rest of your day.